So in this presentation, we'll talk about patients with GI symptoms, whether that be nausea with or without vomiting, nausea and vomiting with or without diarrhea, maybe just plain diarrhea, maybe abdominal pain, maybe all of those together, and always worried about that GI bleed. Our standard assessment flow chart. If it's not a code yet, then we're going to work on CVO. And some of these patients can have circulatory problems. Some can have ventilation, oxygenation, but probably circulatory system issues are the ones we're going to worry about the most. Maybe there's some emergent interventions there, although not very often with these patients. Maybe suctioning if they're actually vomiting. But then we're going to head for an investigation. And you know, the bottom line here is that almost all of these things are treated the same. And as long as they're not in hypovolemic shock, then we just need to get moving to try to differentiate whether it is a gallbladder or a pancreas or a kidney stone. You know, for the most part, doesn't make a heck of a lot of sense. Circulation is probably your area of primary focus. Let's make sure that they're oxygenating and ventilating, and then let's look for that hypovolemic shock. Is the patient already in shock? So when we ask you that, don't even think about the blood pressure. BP's got nothing to do with it. If they have skin changes, they're anxious, restless, confused, and they're tachycardic, those are signs of hypovolemic shock. If their blood pressure is 120 over 80, they can still be in shock. So let's don't miss our shock patients because we're kind of hung up on blood pressure. We're smarter than that. How do you treat hypovolemic shock? Well, it's pretty easy. O2 if they need it. Low flow probably doesn't hurt anybody in this case. Keep them warm. Position them lateral recumbent because they're going to vomit potentially and you want to not have an airway disaster. And raise the head of that bed just a little bit. I'm not talking 45 degrees. I'm talking just a little bit. A little bit will make a huge difference because they're going to be riding backwards and they feel like they're standing on their heads. And that's going to make anybody nauseated. So have them on their side. Expect them to vomit. Be ready to manage it. Have your suction ready. Try not to be caught by a surprise when this happens. And then we're going to replace some of that lost volume with our crystalloid of the day. Maybe it's saline. Maybe it's LR. I don't think it really makes any difference anymore with saline shortages. I mean, you use what you got to use. There's some folks out there that think LR is better again than like it used to be. And so stay tuned and know your local protocol and do what you're told there. Regardless, some crystalloids probably in 250 cc boluses followed by a recheck. Probably shouldn't go over 2 liters. You can end up with some issues with dropping their body temp and messing up their clotting mechanisms and dropping their pH with using these crystalloids. But 250 cc's probably didn't hurt anybody in this sort of a situation. And if you need another bolus, then go for that. It's probably the safest way for us to manage things in this day and age. If they're nauseated and they're vomiting, maybe they aren't eating well, maybe their glucose is down. They don't have to be diabetic to be hypoglycemic, so double check that. If you need to give them a little bump, we like D10 better than D50 because if the IV were to infiltrate, the D10 is not near as caustic as the D50 is. And then nothing by mouth. It just makes sense. But we need to just say NPO so that we could prove that you had heard that once at least. Manage nausea with the world's most amazing medicine, ondansetron. I think it's probably not a bad idea for a lot of your patients that are being transported in certain areas to have some very, very safe and quickly administered. Some places have the wafers that kind of dissolve in their mouth. Others have to do it IV. You're probably going to need a line for these guys anyway. And so some ondansetron's a pretty good tool. Look for those GI bleeds. Be very concerned about the patient that's on blood thinners and has some blood in their emesis, blood in their stool, coffee grounds emesis, tarry stools. It's all GI bleed. Maybe you can even smell it. Maybe you can actually see some in the toilet. This is really gross, but I'm telling you, once you've smelled GI bleed, then your nose becomes part of your assessment, and you can integrate all of that. So be sure you ask them about that stuff. If you can bring a sample, I guess that's okay. Just do whatever makes the most common sense for your patient. And then always remember that these could be cardiac patients. Cardiac stuff can show up as GI. You don't have to have chest pain to have a lethal MI. 12 lead is reasonable. I wouldn't say it's absolutely mandatory, but that would be for that young patient with no cardiac risk factors with clear nausea and vomiting for a known reason, but almost anybody else, get a 12 lead. It's quick, it's cheap, it's free, and it adds a lot of data potentially. Other thing to worry about, the other killer, the other lion, tiger, or bear involved in this could be a AAA. If they've got an abdominal aortic aneurysm, that may present as belly pain. Typically not crampy. Typically it's going to be sharp, tearing, because that's what's going on. Their aorta is dissecting, and that's what it feels like. Some may have a palpable pulsatile mass around their belly button, so palpate carefully, and you may be able to appreciate that. You got to do an exam on these folks, but it doesn't have to be particularly detailed. I'd look around, I'd feel around the belly button, I'd ask them where they hurt the most, and I'd push on that last. I think bowel sounds may have some benefit, but they're either on or they're off. I don't know hypoactive or hyperactive, but I can tell you if I hear bowel sounds. I can tell you if I don't hear bowel sounds. Lack of bowel sounds might mean a bowel obstruction, which can be a big deal. In female childbearing age, you've got to worry about all the OB things and the GYN things, and maybe it's an ectopic pregnancy, and so you can add those questions in. But pretty much these patients, you might as well get moving. You might as well get moving and not spend a bunch of time on the scene, because the fix for these guys is at the hospital. There's plenty of time to ask those questions on the way. Pain management, you can do more than just meds, and sometimes you can't even use meds per protocol. Nobody will give you an order for it. A lot of places don't really want to mask that pain. They want a surgeon to see them. That's better and different in other places, but lateral recumbent's good. They may vomit anyway, and that probably helps them feel better to have the knees and hips flex so that there's less stress on their belly. Some protocols will let you give some analgesics, particularly if you really think it's a kidney stone. If they've got flank pain that radiates down into the groin, it was sudden onset, they've had kidney stones before. If you're pretty sure it's a kidney stone, then you may be able to talk your way into some analgesia for those patients. Toradol works very nicely for ketorolac, which is basically ibuprofen, works very nicely for those guys and doesn't give them a lot of nausea. So history and physical. Identify that prolonged vomiting, prolonged diarrhea patient that could be hypovolemic or may even have messed up their potassium levels. 12-lead wouldn't be bad for that. Identify that GI bleed. Look for, talk about, listen for answers, and maybe go look and see or maybe smell blood or coffee grounds in their emesis, bloody tarry stools. Those guys are a big deal when they're taking blood thinners. It can be deadly for anybody, but the ones on a Coumadin can really be in trouble. Palpate that abdomen, check the glucose, get you a 12-lead. The takeaways are manage their CVO, and it's mostly a C thing. It's mostly a circulatory issue. Don't get distracted trying to decide if you can guess right and say, oh, yes, this is gallbladder. And so your wife's cousin's brother's dog catcher may have had a pancreatitis or something, and you've got all this information, but you really don't. ER evaluation's what they need. They need some advanced imaging, some labs, a surgical consult. I mean, don't try to jump to the conclusion and guess the puzzle, because you know what? The treatment's all the same. If they're shocky, treat them for shock. If they're nauseated, let's help them with that. And if they're in pain, let's try to manage their pain as best we can, even if we can't give them any pain meds. But let's don't miss something that kills. Let's don't miss a GI bleed. Let's don't miss a AAA. Let's don't miss something that's cardiac that's presenting as GI. The end.